to introduce today's speaker, Dr. Jürgen Unützer. It's a privilege because Dr. Unützer is really one of the most accomplished leaders in psychiatry in the country today. And it's a pleasure because he's also a good friend for at least the last 2 decades. So Dr. Unützer comes from a small town in Germany. He migrated to the US as a medical student. He got his MD at Vanderbilt, then did his geriatric psychiatry fellowship at UCLA. Subsequently obtained his MPH from University of Washington, and is presently professor and chair of psychiatry and behavioral sciences at the University of Washington in Seattle. He has published more than 225 peer-reviewed papers, including in major journals like JAMA, New England Journal of Medicine, and others. He has received multiple grants from the National Institutes of Health, as well as various other agencies, foundations, and so on. He was a senior scientific advisor to the World Health Organization and also an advisor to the President's New Freedom Commission on Mental Health. Dr. Unützer has received multiple awards. There's a really long list, but including those from the American Foundation for Aging Research, American Association of Geriatric Psychiatry, American Psychosomatic Society, and also the Depression and Bipolar Support Alliance. Dr. Unützer is really one of the foremost health services researchers in the world. He developed the impact therapy for depression, which really has revolutionized the treatment of depression in primary care, including diseases such as diabetes. It's really remarkable, this work, because he developed this intervention which sounds both simple and brilliant. And he tested it in hundreds of patients in various settings, including Kaiser and various other primary care settings, using the randomized control design, which is really unusual in this arena. I always think about this, that if you ask people what are the 10 top discoveries in medicine in the last 2 decades, usually people will talk about some genes discovered in association with diseases, or understanding molecular mechanisms of certain conditions, or discovery of a new drug that cured colon cancer in mice. But most of these are promissory notes. They may help healthcare in future. Dr. Unützer's work is something that improves the care of patients today. So to me, that's one of the most important discoveries in the entire medicine in the last 15 years. And it's especially relevant for psychiatry because it shows how psychiatry can affect the mainstream healthcare. Showing, for example, that the treatment of depression in diabetes improves diabetic outcomes and reduces healthcare costs, helps people in other fields understand the importance of psychiatry. And to me, that's also important for reducing the stigma in psychiatry. That we not only treat serious mental illnesses, but we also treat illnesses like depression in primary care setting as well as in the context of various medical illnesses. So to me, it's really a pioneering discovery. And so with that in mind, then please welcome me. Please join me in welcoming Dr. Jürgen.
Wonderful introduction. I'm going to wire myself up here for a second. You all let me know if you can't hear me. How's this? Very good. So thank you again, Dylan, for this wonderful introduction. It's a real pleasure to be here with you, and I hope I can deliver on some of the nice things that Dylan said here in the next 45 minutes. I'm going to start with a little bit of disclosure. As Dylan said, I'm at the University of Washington. My primary appointment there is in the School of Medicine. I chair the Department of Psychiatry there. I also have adjunct appointments in our School of Public Health in Global Health and in Health Services. And I do a whole bunch of grant and contract supported work in the area of integrating behavioral health care and the rest of healthcare. And all of the funders for the last couple of years are on here, federal and foundation funders. I don't do any work for pharmaceutical or device manufacturers. And I don't believe I have any conflicts that are specific to this talk that I'm doing today. In addition to working in the department, I direct a division in our department called the Division of Integrated Care and Public Health. And this is a group of friends and colleagues, including my mentor right in the middle here, Wayne Caton, who've worked together on and off really for the last 20 years to try to make the case that psychiatry has got value and healthcare that's outside of settings that are we would traditionally consider places where you get mental health care. So we have a value that goes beyond mental health care. And we do a lot of work in primary care settings. We have a portfolio of work where we're doing work in schools. We do work in senior centers. We do work in nursing homes. We basically try to say, where else are there patients who have mental health needs that are really not getting them met? So I think we discovered some time ago that most people who have mental health needs, and I'll show you a little data on that in just a bit, actually are coming to see a psychiatrist. And if we want to make a difference in terms of public health, we have to go where they are and see what it is we can do to help there. I'm going to start with a little context. So we're in 2014. We have just seen the passage of what may have been the biggest change in healthcare legislation in some time. That's the Affordable Care Act. And I think that, as controversial as it's been, is going to bring us some fabulous opportunities in mental health. So with the Affordable Care Act, we have seen Medicaid expansion. And if you follow the intent of that law out for the next couple of years, a little bit of a noise here, then I think what that means is that as many as 60 million Americans either will have new coverage benefits for mental health services or better benefits for mental health services, because along with Medicaid expansion, Affordable Care Act really has taken all the way, healthcare parity for mental health disorders. So whatever was left in terms of special limits on mental health benefits in Medicaid, for example, has gone away with the Affordable Care Act. So there really are no different limits or no different co-pays anymore for mental health services now than there are for any other medical services. So in a way, that's a wonderful thing, but that's also going to be an enormous challenge, because those millions of new patients who are often relatively poor have also a very high burden of mental health problems. And if all of these folks now have better mental health coverage, we're already saturated in terms of our capacity to deliver on existing mental health needs. We're going to have to be very smart about how to go about addressing those mental health needs. The other thing we are now is we're in an area of accountable care. We're building things called accountable care organizations. My healthcare system, UW Medicine, is becoming an accountable care organization. And what does that mean? That means that we're assigned contracts with large area employers, such as Boeing, in our case, to say we're going to provide all the health care for your employees in a way that's good health care, but also that's affordable. And that's going to create interesting opportunities and challenges for us. And in that context, the reality is patients, and I'll show you some data on that in a minute as well, patients who have mental health conditions have about 2 to 3 times higher total healthcare costs than patients who don't have mental health problems. And if we want to be responsible for those costs and accountable, we'll have to be very smart to think about what do we do with all these extra costs. Right now, these costs are a wonderful thing for our academic medical centers, because that's how everybody pays their mortgage. We sell lots of high-end, very expensive services in places like UW Medicine and UCSD Medicine. But at some point, we're going to have to think about the cost of all of this when we do become an accountable care organization. And at the micro level, at the clinic level, people are really trying to get their heads around this context, this concept of what a patient-centered medical home is. Those of you who are in primary care are very familiar with this term. At the clinical level, that's what we're trying to build. Small organizations that really can provide a good base for a person's care, starting with good primary care and involving specialty care as needed. And when you look at the NCQA regulations that are proposed for 2014, to be certified as a patient-centered medical home now, you have to be able to demonstrate that you have pretty substantial capacity in your medical home to address mental health and substance abuse needs. And that's a really interesting opportunity for us, but also a tremendous challenge. So that's a little context. I'm going to start with some data. This is from a colleague of mine at the University of Washington, Chris Murray. Chris worked with me in 2000 at the WHO, and since then we've both ended up at the University of Washington. Chris is a really brilliant person who has worked for about 2 decades now on trying to measure, quantitate the burden of illness, looking across the world and looking at all health problems that we have and saying, what are the big drivers of both mortality and disability? And they just published the entire December issue of Lancet 2012 was basically devoted to this study. What they published is the most recent estimate as to the global burden of disease. And what they concluded there is when you look at disability, and they have a metric called years lived with disability. If you look at disability, behavioral health disorders, mental health and substance abuse disorders drive 23% of disability worldwide. Depression alone, so depression is just one mental health problem, drives 10% of all years lived with disability. In fact, depression drives 3 times as much disability as diabetes, 8 times as much as heart disease, and 40 times as much disability caused by depression than from cancer. Now, if you walk around this campus here, you wouldn't think that way, because there's a lot of heart disease research, and there's a lot of cancer research, and there's beautiful buildings devoted to cancer and heart disease, probably, and maybe to diabetes, not so much for depression. So there is a bit of a disconnect there. Now, you might say, how could it be that it's 40 times more disabling than cancer? So I'll explain that a little bit. So if you develop a cancer, it's a pretty tough thing to deal with in the short run when you're coping with it. But most of us get a cancer in our 70s, maybe in our early 80s, maybe in our 60s. And when we have it, it's a tough thing to deal with. But maybe we have treatment for it, maybe we make our way through. We now have lots of cancer survivors. The difference to depression is most of those folks who have serious recurrent major depression, we develop our first episode in our late teens, in our early 20s. If that's not well managed, that becomes a chronic recurrent disorder that we struggle with on and off for most of our life. This is also true for, of course, bipolar disorder, for schizophrenia. Most serious mental disorders start relatively early in life, and then you're struggling with them most of your life. So the cumulative burden in terms of disability is just much greater, because you get 50, 60 years of it rather than 3 or 4 years that you're struggling with some kind of cancer. So this is an enormous burden in terms of disability worldwide. Our employers see this a little bit different. So in the U.S. workforce, our larger employers are getting very savvy about the fact that things like depression are causing them huge problems in their workforce with absenteeism. So these are folks who are depressed and not showing up to work. But actually, this is an interesting thing here. When I talk to folks at Boeing, this is actually more what they're worried. They call this presenteeism. So absenteeism is pretty clear, right? The person is sick, they can't go to work. Presenteeism is a person is at work and everybody wishes they weren't at work. You know, that's what I'm talking about. This is a big challenge. And when you're in a company that assembles airplanes, too much presenteeism is a pretty high-risk situation there. Somebody makes a couple of mistakes and you've got some big problems down the road. So they're actually very interested all of a sudden in this. So I've talked about disability, and I'm going to talk a little bit about mortality. Depression is also a pretty significant driver of mortality. Worldwide, we have about 1 million suicides a year. In this country, roughly every 15 minutes, somebody takes their life. In my state, in the state of Washington, we have 3 or 4 suicides every day. In fact, we have had for some time significantly more suicides than homicides. Now, you wouldn't think that if you open the newspaper on any given day, right? There's not a lot of stories about people killing themselves. There's lots and lots of stories about people about homicides, unless you're incredibly famous, you don't make it into the newspaper when you have a suicide. But it's a huge challenge. And if you look at this, there is some debate about this, but I would say the vast majority of patients who commit suicide have some form of depression, often also substance abuse. 50% of suicides, people estimate, you have both a mental health disorder and substance abuse involved. These are all potentially treatable things. Depression also kills in other ways. And this is really a nice summary. 10 years ago, Wayne Caton, who was my mentor in Seattle, published this in Biological Psychiatry on a decade's worth of work looking at how does depression affect other chronic medical disorders. In this case, it's diabetes. And what they basically have demonstrated over about a beautiful set of work, about a decade or two of work, depression and diabetes are very closely related in very many and complex ways, and it's really bidirectional. So if I have type 2 diabetes today and I develop a major depressive episode, a couple of things will happen. At the tail end here, what's going to happen is I'm going to have, earlier than I would have otherwise, both the microvascular and the macrovascular complications associated with diabetes. I'll have poor symptom control. I'll have a lot more functional impairment related to my diabetes than if I was a person who didn't have depression. I'm also going to have significantly higher mortality. Now, how is that? How is that? Well, there are probably really two main areas of driving that. The first one is a behavioral one. So if I have a serious depression, I'm not going to be able to quit smoking as easily as another diabetic. I'm going to have a much more sedentary lifestyle. I'm going to struggle with obesity. And I'm going to have a very difficult time taking my medications every day. I'm going to have serious problems with really good adherence. And good diabetes control requires very tight adherence to medication management. But I'll also have a whole bunch of interesting psychophysiologic changes. My insulin sensitivity will go down. My autonomic nervous system is not well regulated. We'll have serious increases in inflammatory markers and cortisol. And I think between that, what we see is major depression actually a significant driver of mortality in patients with diabetes. This has also been shown in heart disease and a number of other chronic medical illnesses. Finally, this turns out to be very expensive. This is work that I did now, published 20 years ago in JAMA, where we looked at depressed patients, 2,500 depressed patients. And what we, 2,500 patients, older adults in an organization like Kaiser. This happens to be Group Health Cooperative in Seattle. And we broke those folks down into 4 groups. People who are essentially very healthy, no chronic medical illnesses. People who have 1 or 2 chronic medical illnesses. People who have 3 to 5 chronic medical illnesses. And people who have a lot of chronic medical illnesses, 6 to 16. And in every one of these groups, we stratified folks into folks who have essentially no depressive symptoms. People who have mild depression, so dysthymia, subthreshold depression, and people who have full-on major depressive disorder. And when you look at that and you look at healthcare costs in every one of those groups, you see the more medical illnesses you have, the higher your healthcare costs are. These are annual healthcare costs. But within every one of these groups, there is a nice, well not nice, there's an interesting dose-response relationship. And the more depressed you are, regardless of what your level of medical illness burden is, the more healthcare costs you have. And it's a pretty significant difference, $2,000 more, actually $3,000 more here in healthcare spending if you're a person who has a lot of chronic medical illness and depression. Now this data is 20 years ago, and it was interesting enough back then where JAMA published this, but it's become a lot more interesting today because all of a sudden now we're really worried about healthcare costs because healthcare is bankrupting the United States. And the big employers are saying that's their #1 driver of not being competitive in a global market because they're spending so much of their money on healthcare. This is some interesting data that actually is going to be released tomorrow in Washington, D.C. This is work that the APA commissioned from some actuaries at Milliman, and I'll give you a little heads up about it. What they've done there is they've taken a look at several million people's healthcare claims. They've looked at people who have commercial health insurance, Medicare insurance, and Medicaid insurance. And they've said, in all of these populations, what is the percentage of people who in any one given year have at least one healthcare insurance claim for a mental health disorder? So you see across all payers, about 15% of people walk out of a doctor's office in any given year with a diagnosis of a mental health problems on a health insurance claim. And I would say that's a conservative estimate because there are lots of people who go to the doctor, who probably have a mental health problem, but the doctor doesn't code it. So this is a pretty conservative estimate. So you can see in Medicaid it's a little higher. 21% of Medicaid patients have mental health problems, 9% in Medicare, 14% in the commercially insured. And then what they've looked is they said, over the next year, what is the cost to the payer in terms of total healthcare costs? And the way they look at this is they said, the average person, what is the per member, per month cost to the payer? So now you can see if we look at the all insurers row here, about $397 per member per month if you don't have a mental health problem. If you have a mental health problem, over $1,000, so a 173% increase in total healthcare costs in the group that has a diagnosis for mental health problems. This is a huge challenge. This is even bigger in Medicaid. Look at this. $381 for a Medicaid patient who doesn't have a mental health problem, $1,300 if you have a mental health problem. Now, most of these costs, these extra costs, are not people seeing a psychiatrist or psychologist or getting mental health care. Most of these costs, as you might imagine, are lots and lots of all kinds of health care use. More ER use, more urgent care use, more outpatient, more inpatient medical use. If you have an inpatient hospitalization as a person with a mental illness, you have significantly longer lengths of stay. So this is a huge challenge for our country. And in fact, mental health specialty care accounted for only about 3% of the total cost. So we're not the big spenders here. But the conditions we treat are a big driver of healthcare costs. So in a sense, what you would say is there must be an opportunity here. There must be an opportunity for us to go in and treat some of these disorders and see can we get better patient outcomes and can we save some of this money. And I think that's a fabulous opportunity and challenge for all of us. Now, I'm going to switch gears a little bit and talk a little bit about how good our healthcare is. I'm going to start, and I'm going to stay with depression because depression is a condition that's common, it's pretty well understood, and I think it's a good indicator. So if you have a major depression and you live in the United States today, let's say everybody in this room has a major depressive episode, and there's about 100 of us here. What will we see over the next year? Well, 2 out of 10, so 20 out of 100, would go see a psychiatrist or a psychologist. 5 out of 10 would have no care whatsoever. That's not on this slide, but only about 20% of people who have major depression will see a mental health specialist in any given year. 5 out of 10 will get treatment for depression in primary care. That's a huge change from when I started in this work about 20 years ago. Back then, primary care doctors were not commonly treating depression. Now that's incredibly common. In fact, about 30 million times a year, somebody walks out of a primary care doctor's office with a prescription for an antidepressant medication. So depending on how you're wired, I'm a glass is half full kind of person. So I think that's pretty good because that means there's a lot of recognition of a problem and people are trying to do something about it. But it turns out to be really challenging. Is a really fun study published in the Journal of the American Geriatric Society a couple years ago by an economist who was up there in Palo Alto, Ming Tai Seal, and what she did is she got a hold of videotaped visits of older patients with primary care providers, 384 visits. And she studied very carefully in a quantitative way what happens in these visits when the person has depression. And what she found out is if a person had depression and they went in to have a primary care visit, the total amount of time devoted to the discussion of anything related to mental health, to the initiation of a treatment, prescription of an antidepressant was 1 minute and 59 seconds. So the title of the article was the 2-minute mental health visit. Now, you might say that's terrible, but I'm going to show you some data in a bit that actually puts that in a very interesting perspective. These folks are busy. They have to do a lot of things. The patient didn't come in for depression. The patient came in for who knows what, some symptom complaint, and they're having to do preventive care. They have to manage your diabetes, your heart disease. They have to make sure you've got your colonoscopy if you're over 50. They have to talk to you about smoking and alcohol use. They have to talk to you about are you wearing a seatbelt, are you wearing a helmet, and then they sort of look at you and they say, wow, this person looks really depressed, and I got about 1 minute left in my visit here. It's a challenging task. We have Dave Folsom and a couple of other PCPs here, so you know what I'm talking about. And so I think the interesting thing actually is we now have a ton of psychopharm use. This, I don't know if you can read this caption. It says, of course you feel great. These things are loaded with antidepressants. In fact, 10% of the US adult population in any given day has antidepressant medications on board. It's probably true in this room as well. Probably higher in this room, I'm guessing. Because you're all kind of aware. But that's a really interesting thing. And if you follow those 30 million prescriptions out, what you find out is that a year later, about 25% have a significant improvement in their depressive symptoms. So that's the class that's half therapy. That's not so hot. So we've got a lot of treatment. It's mostly not done by psychiatrists or psychologists. There are lots of reasons for that. But the treatment's not terribly effective. So that's where we are. And I'm not judging that. I'm not saying that's good or that's bad. That's just how it is. And our colleagues in primary care are very well aware of this. So when they were surveyed, this was a fabulous study published in Health Affairs a couple of years ago. Primary care doctors in 60 U.S. communities were surveyed about their access to specialty care for their patients when they needed one. And mental health, as you might, maybe not a surprise to you, was at the rock bottom. 66% of these primary care providers said, I have no very lousy access to mental health care for my patients. So this one says, we couldn't get a psychiatrist, but perhaps you'd like to talk about your skin. Dr. Perry here is a dermatologist. Now, I'll offend somebody here. So I showed this slide at one of our primary care clinics in our academic healthcare system a few months ago, because I was trying to make the case to them that they should have some mental health services on site in their primary care clinic. And one of the physicians in the room said, wait a minute, she said, we actually have 2 dermatologists who work here at this clinic, you know, and they're very well received. Our providers like them, our patients love them, you know. When you look good, you feel good. That's actually a very good thing for mental health. And there was a guy sitting in the back of the room, one of the older docs, and goes, yeah, he's going to look good going down. So I hope I didn't offend anybody too much. I didn't make this up. It was just kind of a funny experience. All right. So what about psychiatrists? You know, what do we do? Where are we at? What do we do? So there's 40,000 psychiatrists, roughly, that practice in the United States. That's about 13 psychiatrists per 100,000 population. And aren't we helping with this problem somehow? Or how could we help with this problem? So basically, one of the challenges is they're all very poorly distributed. They're all in major urban areas. They're all, you know, in places like San Diego. In fact, half of them are in this room. There's lots of parts of San Diego County where nobody's ever seen, will ever see a psychiatrist. I can guarantee you that. So we're not very well distributed. In fact, about half the counties, about 55% of the counties in the United States don't have a single practicing psychiatrist or psychologist. Just as many people in those places that are struggling with mental health problems. So very poorly distributed. In the state of Washington, we have about 700 psychiatrists, and 612 of them are in Seattle, and 58 are in the rest of the state. So we've got a big distribution problem. So a couple of months ago, in our research team meeting, we did a little fun little exercise. So what I said to my team is, I said, look, with our residents, what we teach them is what we sort of consider ideal. We teach them to do what we call a 50-minute hour. We basically teach them how to go in a room with a patient and spend 50 minutes and do a nice assessment and make a treatment plan and maybe get started on some treatment. It takes about 50 minutes, and then, you know, have an hour to do some charting, to get a cup of coffee, to go to the bathroom, and then you do another one. That's a wonderful thing. That's a very good thing. That's kind of what we like to do. Now, if we make a couple of assumptions, if we take all 40,000 psychiatrists, and we make the assumption that 3% of the US population at any given time has the kind of mental health need that would benefit from a psychiatrist. I'm going to say that's a very conservative assumption. 3% is a very small number. You know, if you look at the epidemiology of virtually any disorder. How much time would we actually have? So if you do the math, basically what you have is if you're living in San Diego or Seattle, that psychiatrist has about 6 minutes for you. If you're living in the rural United States, it's about 1.5 minutes. So we're not teaching people the kinds of skills they need to be effective, certainly on a population level. In fact, we need to learn how to talk much faster. minute and a half, very, very fast therapy. So that minute and a half isn't actually all that different from what that primary care doctor has. And the primary care doctors are much more doing population level medicine. They're seeing a much more representative sample of the population. So we actually have a shared challenge in some sense. Very interesting. So now, there is no way, I don't know how well you guys do talking your medical students into becoming psychiatrists. Maybe you're a little bit better, you have a fabulous department, maybe you're a little bit better than the average, but right now about 3.5% of US medical school graduates go into psychiatry. If we doubled that number, in about 10, 15 years, this would become 3 minutes and this would become 12 minutes. We're not going to be able to solve all the mental health needs by cranking out more psychiatrists doing 50-minute hours. So I think we have an interesting challenge there. I'm going to say a little bit now about how effective are our treatments. So this is a slide that summarizes a whole bunch of research. The first row here is meta-analyses of antidepressant trial. This is a nice meta-analysis that Michael Face did a couple years ago, where he cobbled together a whole bunch of hundreds of little antidepressant clinical trials. And when you look at them, at the end of the day, about 63% of people who take part in a clinical trial for an antidepressant have what we call a treatment response, so 50% or greater reduction in their depressing symptoms. 47% go to complete remission, so essentially symptom-free at the end of the trial. That's not so bad. I would say that's pretty respectable. That's right up there with any other medical treatment that I can think of. That's not bad. How well does it work in the real world? So here's 3 other published estimates of how well we do with depression treatment in the real world. This is a nice study. Dave Katzenlink did this, who was at Mayo, where he got private practice psychiatrists to agree to routinely measure depression outcomes using, standard rating scales, the same that are used in research studies, for every single patient they saw in their practice. It's a pretty good sample. There's about 20 psychiatrists in private practice that are in this sample. They track their patients for a whole year. And at the end of the day, 36% meet response criteria, 18% remission. Not so high. Quite a big difference from what we see in these clinical trials. This is a study from John Rush. He looked at mental health centers, community mental health centers. So these are more sick patients, more socioeconomically challenged patients that are seen in community mental health care that have major depression. 26% response, 11% remission. This is my own study that I'll talk a little bit more about in a few minutes. This is primary care patients, 1,800 patients, 18 clinics in 5 states. We tracked them for a whole year. 19% of patients who were started on an antidepressant medication in primary care had response. 9% reached remission. None of this looks very exciting. And there's a huge drop from what could be possible, what you see in a clinical trial, to what we actually see in the real world. So that's another challenge we have. We're not actually, quite as good as we think we might be. So we have some challenges about making our treatments more effective. Now you might say, well, antidepressant medication, maybe you're a psychologist and you're thinking, meds really aren't where it's at anyway. People need to have good psychotherapy, and I would say that's a very, very good point. Now, psychotherapy is interesting. So this was a nice study done a couple years ago by a group of very, very smart psychologists, and they looked at the effectiveness of the efficacy of psychotherapies for depressions when people are in clinical trials for psychotherapy. So these are manualized therapy trials, IPT, CBT, PSD. And when you look at these trials, on average, the patient who goes into one of these trials gets about 12.7 sessions of psychotherapy, whatever the psychotherapy is that's being tested. And about 55 to 65% actually improve. So they would meet that response criteria. It looks pretty similar to the antidepressant data, actually. Then they looked at published examples of real-world psychotherapy. There, the story is actually quite different. So about 50% of the patients that are referred to go to psychotherapy from primary care or even from a psychiatrist actually don't go. So you have a huge voltage drop right there. You lost half the people that could get better right there. 30% of the patients will go to psychotherapy and they'll have 1 session and never come back. There's a big voltage drop, again, right there. You lost a whole bunch of other people. Now, those are not the patients you think about if you're practicing psychotherapy, because you saw them once, they didn't come back, whatever. But if you're thinking about it from a public health perspective, those are all people who have depression. They're in the denominator. Clinicians are very good thinking about numerators. Numerators are the people who keep coming back to us and saying, thank you very much, you did such a nice thing for me. Let's do another one. But that's not the denominator. The denominator are the patients who have come and seen us, and we really haven't really done very much. So if you follow things out, the mean number of sessions in psychotherapy, this is true at Kaiser, this is true at group health, this is I bet true in your own healthcare system here, is about 3 to 5. The modal number of sessions is about 2. But that's the most common thing that you see. And there is no manualized psychotherapy for depression that I've ever met that gets anybody snap out of a major depression in 3 to 5 sessions. So that's a very interesting thing. Again, a big disconnect between what could be and what really is. And if you follow it out, about 15 to 25% of people who are getting psychotherapy for major depression in the real world really have a significant resolution of that. So a big challenge there too. So what do we do here? How do we close this gap? So we could do a couple of things. We could train more psychologists and psychiatrists, and we could make us all work a little bit harder. Maybe we should see patients 10 more hours a week. I bet those of you who are clinicians will always be, tracked on your metrics, on your work RVUs, and so on and so forth. So you could add a few more, or we could work smarter. And what I'm going to talk about the rest of this presentation is 2 things. One of them is something called measurement-based care. The other one is really a way to try to leverage that mental health specialist to try to be more effective and reach more patients. And we do that in 2 ways. We do that through partnerships, partnering with primary care providers, with school-based health providers, and we can do that using technology. I'll talk a little bit about both of these. So basically, we need to find ways to practice differently to try to reach more people and to make the care that we do provide be really more effective. So I've done a lot of work over the years with the World Health Organization, and they like a concept called task shifting. And task shifting is basically a very simple idea. Task shifting means, does it really take a psychiatrist who's pretty rare and pretty expensive to do all of this work? Or are there some things that you could actually have somebody else in the healthcare system do? Can you take that complex work that a psychiatrist does, break it up, and shift some of the tasks down? We tend to think up here inpatient psychiatry, consult psychiatry, emergency psychiatry, maybe a mental health center, maybe a psychiatry outpatient clinic. That's where psychiatry ends. And what we have done is we said, what about primary care? What about school-based health centers? What is it that we could do if we partnered well with organizations like that actually are at the bottom of this pyramid where there's a lot more patients than if we focused all of our energy up here at the top of this iceberg, in a sense. So what we did is we built this model that Dylan referred to a couple years ago called Impact. And what we do in Impact here, I'll talk about that around this picture here. So in every clinic that has Impact, there's a primary care provider. So the patient has their own primary care provider. And in every one of these practices, we train a person we call a mental health care manager. That could be a nurse, that could be a social worker, that could be a master's level or doctoral level psychologist. And their job is to work alongside this primary care provider to track a caseload of patients who have depression or other common mental health problems, right there in primary care. And we teach these folks to do a couple of things that are very different from what this guy does. This guy has 1.5 minutes or 2. He'll make a diagnosis. He'll say, you have something called depression. I have a person here in the practice with me that's very good at this, and she and I were going to work together on helping you with this depression. And before you leave the office today, I want you to meet this person. And what does this care manager do? Every time she sees this patient, she gives the patient a PHQ-9. We actually measure how bad the depression is, which is something we actually don't do in most routine care, in mental health care. We follow some pretty standard treatment protocols. If the doctor is doing medications, if it's been 6 or 8 weeks and the medication is not working, we make a change. We teach these care managers manualized psychotherapy. We teach them behavioral activation. We teach them problem-solving treatment. Those are manualized, evidence-based psychotherapies that they can do right there in the primary care setting. The patient doesn't have to go out to see the specialist. What about psychiatry? Do we need a psychiatrist? Okay, every one of these patients is tracked in a web-based tracking system where we measure these PHQs over time. And once a week, I go to the clinic where I'm on the phone with this care manager as their designated consulting psychiatrist. And I have to go over every single patient that's fallen in this clinic who's not having an improvement in their depression scores. And I have to make a recommendation about what to do. Occasionally what will happen is it's been the 2nd or 3rd time they're talking to me about a patient, and I don't really know what to do, and I say I need to see this person. But now I'm not seeing all the patients. I might just see 10, 15%. And in fact, I can now do this. We do this, I'll share in a little bit. We do this in 150 clinics in our state. And many of them are 3, 4, 5 hours away. I just do this using telemedicine. In fact, that care manager hands my patient an iPad and says, let me introduce you to the doctor at the university. And I do a very nice interview with that patient. It might take 10, 15, 20 minutes. And my question is really, I've already heard a lot about this person. I need to sort out if this is a person who's got bipolar disorder. Maybe they have, they're presenting in a depressive way, but maybe they got bipolar disorder. And I can really figure that out. And then I'll make a treatment recommendation back to this guy here, and he can change medications. I'm also available as their consultant by phone anytime they have a problem. It's very rarely used. About every couple of weeks I get a call from one of these docs, because these primary care doctors are busy. They're running from patient to patient. They don't feel like, oh, let me take 15, 20 minutes and call the guy. They really only call me when they really need me. I never feel like it's a bad call. I'm very comfortable with this. So this is a different model. This is a model where I take that specialist and I leverage them through a set of other providers, through some very systematic tracking. And I only hear about patients who are not getting better. And that's where I have to come in. That's my job as a psychiatrist. I need to help them get unstuck. Occasionally we'll say this is too complex to manage in primary care. This is a person who needs a case manager, they need dual diagnosis treatment. We can't do that here in primary care. Then we have to make them a good connection to the specialty system. But it's actually a small number of patients that we can't take care of in primary care. So I'm going to speed up a little bit here. We tested this concept in a very large randomized controlled trial. We actually went in 8 healthcare systems. We took about 200 patients in each of 8 healthcare systems. About 1,800 patients total. And in every one of these healthcare systems, 100 of them got typical primary care, and the other 100 got this impact care model. So every other patient got randomly assigned to either working with their primary care doctor, and what did these doctors do? 50%, so the patients who were in the usual care control arm, 70% of these doctors wrote a prescription for an antidepressant medication. So they were all getting antidepressant medications. 20%, the doctor said, this is too complicated, refer to a psychiatrist. So that was our usual care control arm. Not a placebo group, a treated group. The other half, same doctor, same primary care provider, but we added the care manager, we added the systematic measurement, and we added that psychiatric consultation. And if you look a year out, this is our primary study outcome, published in JAMA. What we found is across these 8 healthcare organizations, on average, the usual care patients, 19% of them had a response to depression treatment, 50% or greater improvement in their depression symptoms a year out. With the impact model, we more than doubled that. We got that to about 50%. That's a huge difference. In fact, there's a San Diego-based clinic here. This is the Kaiser Clinic in La Mesa. Same thing there. We roughly doubled the likelihood that we got these patients better. That was pretty exciting, but a lot of the folks I worked with on this study were not psychiatrists or psychologists. They were internists and family doctors and said, yeah, depressive symptoms, that's kind of subjective, that's kind of squishy. What about physical functioning? How do these people do in terms of their physical functioning? And we used the SF-12 physical component summary score, and what we found is our usual care patients gradually declined in their physical functioning over the next year. Our intervention patients, those who were getting impact care, significant improvements in physical functioning. Even we stopped this intervention right here after 12 months. Even 24 months out, we went back to that group and did another independent assessment, blind to treatment status. We still had much better mental functioning and physical functioning in the folks who had gotten this integrated care. And finally, people said, how much does it cost to do that? Well, it cost us at that time about $522 to provide a year's worth of primary care depression impact care. So that's the cost of the care manager, the cost of the consulting psychiatrist. And that's a unique cost that was only there in our intervention patients. But we were able to track total healthcare costs for 4 years, for all 1,800 patients in this program. And what we found is 4 years out, when you look at the difference in healthcare spending in these 2 groups, every single category of healthcare, we saw reductions in healthcare costs in the group that had gotten impact care, including lower outpatient mental health costs, lower pharmacy costs, lower inpatient medical costs, lower outpatient medical costs. And at the end of the day, for every dollar we spend, so these $522, we see $6.50 in healthcare cost savings. So that was pretty exciting. We didn't know this word back then, but if you read the language of healthcare reform, that's what's called the triple aim. We had better clinical outcomes. We have more satisfied patients and providers. Because both the patients and the providers were much happier with this kind of integrated care than with the traditional referral out care. And we actually had significantly lower healthcare costs. That's what's called the triple aim. And it's a very nice thing that we can say we have something in psychiatry that can do that, because everybody's chasing this triple aim thing right now. And it's actually not so easy to try to get there. All right. Now, I'm a researcher, and when you do a study that works well, you do more studies. So what we've done is we've gone out and replicated this basic study with a whole bunch of other populations. We've done this with depressed diabetics, with depressed cancer patients, with depressed adolescents. I've done a study where we've taken older adults with arthritis and depression. And Karina Davidson in New York has done a really nice study where she did this model with patients who have heart disease and heart attacks. And every one of these studies basically are replicating the basic finding. When you do this kind of systematic, measurement-based, integrated care, where you have good collaboration between mental health and primary care, you're going to get better outcomes. In this study, actually, we saw statistically significant reduction in cardiovascular mortality for the patients with better depression treatment. They actually have a huge NHLBI grant right now to try to replicate this on a larger sample. So this is all really cool, and it's gotten us lots of papers, and it got us, some of us tenured and promoted and other kinds of nice things, and that's all wonderful, but it actually hasn't helped patients out there in the real world. The last 10 years, and I got about 5 minutes, so I'm going to wrap up and talk about a 10-year journey of sort of saying, when you have a big research finding like this, how do you go out and take it out into practice? And everybody's now talking about translational medicine and going all the way from the bench to the bedside out into public health. And it turns out that last step out is a huge step, and it's much more challenging actually than running a huge multi-site collaborative care randomized controlled trial. Because everybody listens to the story and says, yeah, that sounds really neat. And I'd like the world to be that kind of a world. Now, if everybody around me changed a little bit and I don't do anything, it would be really good. This is not a simple intervention. This is a highly disruptive intervention that touches everybody. The primary care doctor has to do things differently. That care manager is not trained to work in a primary care setting. They have to learn how to work differently. That psychiatrist has to learn way to work differently. There's a lot of psychiatrists who say, that's not real psychiatry, that's crazy. You mean I don't see all the patients? Like, what are you talking about? What about liability? So there's some challenges. This is a really disruptive way of going and changing practice, and that kind of practice change is not easy. It's not as simple as saying, hey, the green pill is pretty good, but now we have a purple pill. How about stop writing for the green pill, write for the purple pill? That's a really simple practice change. It may or may not make a big difference. This is a disruptive change, so it's challenging, but it can be done. So a couple of years ago, I complained to a buddy of mine. I was at UCLA at the time. I was at UCLA before I went to the University of Washington. I actually did most of this trial when I was at UCLA. And I complained to this guy that we had done this fabulous study, but nobody's doing it in the real world. And he said, well, I'm in the movie business. This is a guy who makes movies. He said, how much did you get for distribution? I said, what are you talking about? He said, well, how much was the thing you did, whatever the grant you said? He said, it was $10 million, which back then was a lot of money. He said, how much you get for distributing it? He said, what are you talking about? He said, I make movies. I go into the studio. I have to, if they're going to give me $10 million for making the movie, I have to show them that I've lined up $20 million to distribute this movie. Because if I don't have that, nobody will go see my movie, and they won't let me make it. I thought, that's interesting. And then I talked to a guy who was the medical director at Merck at the time, and he said, oh, it's the same thing with us. He said, when I started at Merck, we were all about R&D. Now, 10% of our budget is in R&D. 80% of our budget is in our distribution system. I said, what is your distribution system? He said, it's hundreds of thousands of people, who can go to every doctor's office, the day after the FDA approves your drug and says, stop writing for the purple pill, it's now the green pill. So that's where our money is. I thought, that's interesting. We discover all kinds of things, right? In psychiatry and the rest of medicine. We don't have a distribution system. So that's an interesting thing. But we decided, okay, we have to try to take a crack at this. So we built a distribution system. We built a program called the AIM Center, which stands for Advancing Integrated Mental Health Solutions. And we've gone about 10 years trying to figure out what does it take to take an idea like this and take it out. And so we have now trained a little over 5,000 providers in, actually this number is a little bit old, in about 700 clinics in the United States to do this model of care and to continue to track the patient outcomes. And I have all the data from all of these clinics now, so I can see does the thing still work when you take it out in the real world? Because maybe it worked really nicely in the trial, but what about the real world? So we have done this now. In our state, we have 148 clinics that have this program. We have worked with 80 clinics in Minnesota to do it. We've trained 100 clinics in LA County. So we've got now a lot of clinics in the real world that are out there doing this. We've also trained, working with Dave, some clinics here in San Diego doing the impact model. In our own healthcare system, this is UW Medicine. This is the Puget Sound region near Seattle right here. We have put this integrated behavioral health care program into 11 primary care clinics. 4 of them at our county hospital, Harborview. 5 of them are clinics that are all over the Puget Sound region. These are our UW Medicine neighborhood primary care clinics. And one of them is our general internal medicine clinic at our hospital-based clinic in Seattle. In the first year out, we saw that this thing was actually dynamite. In the first year out, we saw over 1,000 patients. We had a very high rate of improvement. I set a target. I said I want to see 50% of these patients a year out meeting these kinds of response criteria that you would look for in a clinical trial. So 50% or greater reduction in measurable depression symptoms. And we also measured on anxiety. So we measured depression with the PHQ-9 and anxiety with a tool called the G87. And guess what? In the first year out, we substantially exceeded this with our first 1,000 patients. We've got 71% of these folks to have a treatment response for depression. And our patients and providers love this. This is a nice quote I got from a provider last year. I'll let you read it yourself. This is the medical director of one of our primary care clinics. They said, finally, these people in psychiatry, they're doing something that's useful to me. I don't know what they do. They're over there in their silo, you know. I send them a patient, I never get anything back, you know. Occasionally they get a cryptic note back that I don't really understand very well. Now they're right here working with me. These people are really cool. We also had an interesting experience. We started doing this, and at some point we got interviewed by a lady who writes for the Wall Street Journal, and she wrote this really nice article called Mental Health Care at the Doctor's Office. This is interesting. It was a New York-based reporter who basically said, you know, when you're in New York and you have a mental health problem, you don't go to see a primary care doctor, that's for sure. You know, you go to see your analyst and your psychopharmacologist and maybe someone else. So this was an amazing discovery for her. You might just go to a doctor's office and you might get reasonable mental health care there. So she wrote about that, and it's interesting because this article has gotten us more press and more traction than you know, papers in the New England Journal and in JAMA. So if you really want to change the world, don't talk to the New England Journal of Medicine, talk to the Wall Street Journal. And it's interesting because this is exactly 10 years after we published the original article in JAMA. So there's that talk about, you know, it takes 17 years for an innovation to go from, you know, the discovery to real world practice. It takes about 10 years from the main, you know, from the business, for the business literature to pick up an idea, you know, that was proven, you know, in a medical journal. Last couple of comments. So we've also had a wonderful opportunity in our organization the last couple of years working with our state and with a managed Medicaid company in our state. So this is a company that provides managed Medicaid. And with our county, King County, Public Health of Seattle and King County, what they said is we have a lot of folks, they're never going to see a psychiatrist, and when they do, they don't get terribly good care. Can you take this program and put it out into a lot of clinics where our Medicaid patients are? And so we did. So we now have put this program out into 148 clinics all throughout our state. This is the state of Washington. We're kind of urban here, that's where most of it is, but then the rest of the state is this very big rural area. In every one of the counties, we have at least one clinic that can provide this program. And I have a contract with this Medicaid plan where they pay me for 5 FTE of psychiatrists, and those psychiatrists do just that. They are each designated to one or more of these, clinics, and they do this case reviews, they do treatment recommendations, and when things are complicated, they say, give the person the iPad. And they can do a very nice assessment. And you know, the nice thing for what we do is we don't have to touch the patient, you know, to do a good assessment. Maybe we actually shouldn't be touching the patient. But you know, we can do a lot using technology and using this kind of a systematic approach. And so we have now served over 40,000 clients with 5 FTE psychiatrists. We've developed a really nice web-based tracking tool that we license that is in use in some 14 states. We track the care of about 80,000 patients at any given time with this tool. And we can very nicely see, is the care working or not? This is roughly what we see across our 40,000 patients in our state. Most of them have depression, but we also treat people who have anxiety disorders. We treat patients who have post-traumatic stress disorder. We have patients where the primary treatment goal is alcohol and substance abuse. And this was a bit of a surprise. 15% of the patients we care for in this program have full-on bipolar disorder. And we can actually do a very nice job managing them, as long as we can track on them. They don't all have to be primarily managed by a psychiatrist. 45% of the patients who come into this program have thoughts of suicide. These are not the worried well. These are some pretty sick people. This is a little bit too much to read in detail, but the bottom line is here, all of the populations we're serving are having pretty good outcomes. This is very real-world data, 40,000 patients, and somewhere between 40 and 60% of patients meet these depression response criteria that you would also want to see in a clinical trial. That's now pretty close to what is possible when you look at clinical trial populations. This is a nice quote, and the reason I'm showing it to you is because it comes from Eric Turner. Eric was one of your faculty for a long time. He moved to Seattle a couple years ago, and he said to me, I want to do a little clinical work. I said, Eric, you're a really experienced clinician. I'm going to put you out and work with a couple of these clinics. He has loved it. He's been a fabulous consultant to a couple of clinics in some very rural parts of Washington. He goes out there and meets with the doctors. They love him. He's a very smart guy. And I'll let you read this. He said, this is what makes me feel good as being part of a large state-funded healthcare organization, because I feel like I'm actually doing something, for people in our state that we otherwise really couldn't help very much. Okay, one more comment. A couple of years ago, we had this program going in 140 clinics, and some clinics were having really good outcomes, and I track all of these outcomes with our web-based tracking tool. Some clinics not so good. So I thought, this is not good, because I want them all to be good. I want them all to be like we had our clinical trial. And so what I said to the health plan is, some of these clinics are not, they're taking the money, but they're not really doing the whole thing. They're not consulting us when the patients aren't getting better. They're not making changes in treatment when the patients are not getting better. We're just going to do one more session. I want people to keep making changes in treatment until the patient gets better. And so what we did is we said, okay, how do we get there? So I just said at a bit on a whim, I said to them, take 25% of the money you give those clinics for the care and tie it to either showing us that you got the patient better, or that they're making a change in treatment when the patient's not getting better. So I thought that way they will drive more psychiatric consultation, more changes in treatment. And they said, there's no way that's going to work. That pay-for-performance stuff, it doesn't work anywhere. It certainly won't work in psychiatry. It definitely won't work with these clinics that mostly treat low-income patients. These clinics, these patients are hard to treat. You got to be smoking something. So we did. They put that, they changed their contract and said, now 25% of the money goes for you either showing us that